Thank you for, excuse me.
Sorry
Thank you for, that's all right. Thank you for joining me this evening. And as you're well aware, I'm going to be discussing the topic of treating tricky tendons this evening. So let's get started. Clive has already very kindly sort of introduced me, but yeah, just to run through that again a little bit. I'm originally from the very small village of Lambourne in Berkshire, which is famous for its horse racing, actually, an industry that I was really born into. So learnt to horse ride from a very early age. I got my bachelor's degree from Cardiff, my master's from UCL, as Clive said. And I actually originally started working in spinal injury rehabilitation before sort of working into the sort of private sports injury and musculoskeletal field. And I've worked with various different sporting injuries. I've now been in London for 9 years, and I've been at the Putney clinic for a couple of years, which I absolutely love. Really, really great team there. Aside from that, I do some home visits and I work with a few patients around Clapham as well. I tend to like to be quite flexible according to what my patients like and or need. Aside from that, I'm a super keen yogi. I love my yoga. I love watching the ballet. I am a huge fan of the sunshine and love my food, and I'm a little partial to a few glasses of wine. My work has a very functional approach. I really love assessing movement and optimizing movement. And I really believe that we've all got the opportunity and power to really help and improve our own physical condition. I don't think that physiotherapy should involve simply thousands and thousands of exercises, but just small adjustments and the introduction of small habits to our sort of daily lives to help recover from the pain and injury. So let's get talking about the topic. So a brief overview of what I'm going to be covering this evening. I will start by touching on the topic of terminology and determine the exact problem that we're actually covering today. I will cover the basics about what a tendon actually is, how it functions, and how it goes wrong and starts to cause pain. I'll also start to look a little bit, or just lightly touch on research in the area. This slightly helps you understand why we treat them as we do. I'll then look at how they tend to present, probably to you as well as to me in clinic, before moving on to sort of the topic of treatment and how we tend to address them currently. Then lastly, we'll start to look briefly at how we can hopefully prevent these problems before summarizing things nicely at the end. So what are we talking about? Some of these may look a little familiar to you if you're currently struggling with your tendons. Your tennis elbow, or actually in some cases around the elbow, your golfer's elbow. Your rotator cuff tendinopathy, supraspinatus tendinopathy, which affects the shoulder. My favorite, the Achilles tendinopathy, which can affect the mid portion, which is where this person's kind of pointing to, as well as kind of the insertion of the tendon, which is right down and around the heel. Your patella tendinopathy, which is the tendon that connects the bottom of your patella down to your shin bone. On the street, this is actually commonly known as jumper's knee, and is, to be honest with you, most common really in your young jumping male athlete. The gluteal tendinopathy. Again, this is most common in your postmenopausal ladies, and very commonly is actually misdiagnosed. It's often thought of as a referral from the back, but gluteal tendinopathy, really, really common in ladies. And your hamstring tendinopathy. So where your hamstrings come and insert into like your sitting bone, your ischial tuberosity, can create, I suppose, more sort of like buttock pain, really. Very, very common in your sprinters, yogis again, your runners as well, very common. And lastly, actually, I haven't put a picture on here, but quervins, which is a very common tendinopathy around the thumb, common in people doing lots of sort of work on their phones. Actually, I see a lot of it in ladies initially following the birth of their first child, lots of lifting and carrying of the baby. So that gives you a rough overview of tendon problems that I'm going to be covering. So as I mentioned earlier, I'm going to sort of touch on the topic of terminology here, because you'll hear me talking about tendinopathy. So first off, here I am not talking about tendon ruptures, and I am not talking about tendon tears. This is a completely different topic. I'm talking about tendinopathy. And in the medical world, basically, we like to use fancy words to describe various things. We'll often use a suffix. So in the case of tendinitis, itis is a term that's, or a suffix that's used to group together inflammatory problems. Now, as research develops, very often the terms we use to describe particular problems will change according to the research we find, but that doesn't always filter down to street level. So you'll find that a lot of these different terms are used interchangeably and can often therefore become very confusing. But again, for the purpose of this talk this evening, we are referring to the same condition with all these terms, and I will use the term tendinopathy. So let's go back to biology and talk about what a tendon actually is. So a tendon is a really, really strong, tough structure, and it connects your muscles to your bones. It's made up predominantly of collagen fibers, and collagen fibers are the main structural protein that you'll find throughout your body. In addition to collagen, we also have a structure called elastin, which makes up, I think, anything between 1% to 3% of the tendon. And combined, these fibers form a really complex three-dimensional structure that's very, very tough. The fibers will be aligned according to the various stresses that tendon has to withstand. So they'll be longitudinal, they'll cross over, there'll be spirals, really, really intricate fine tuning to form this nice, tough bundle of fibers. And again, the tendon withstands these longitudinal forces, transverse forces, rotational forces. If you think about the stresses you apply to your body, that tendon has to be really robust. Otherwise, the forces would simply rip those fibers apart. And how does a tendon actually work? Well, effectively, you need to think of your tendon a little bit like an elastic band, or, as in the case of this picture, a spring. So a tendon is really flexible, but it also has the amazing ability to recoil, and it does that without rupturing. When a muscle contracts, it will obviously pull on the tendon, and in turn, that will pull on the bone to produce movement. And the elastic recoil of that tendon is really energy efficient, and it helps minimize how much energy we have to use to move. Now, in your jumpers and your really fast runners, we tend to see these really lovely long tendons that also have what we call a high level of stiffness. Now, they have, not to say our tendons aren't efficient, but they have really, really good tendons because they're very powerful, as they have the ability to, as I said, become flexible and recoil to produce huge levels of power. So if we take these three springs, in short, if we look at Goldilocks, we want something between the middle. We don't want one like the end, which will be easily deformed and then doesn't really recoil very much because it won't produce much power. We don't want something in the middle that will require too much energy to separate. We want something in the middle that is easily, well, has an element of flexibility, but recoils to produce this nice level of power. So think about your cheetahs, your lovely, long, strong, powerful tendons that produce this huge amount of recoil to produce power. And that's ideally what we want from an efficient tendon. So for the purpose of this talk going forwards, I really need to emphasize a few points. First off, most of the research that's out there in regards to tendon management really does focus around the lower limb. So we're talking about your gluteal tendon, your Achilles tendon, your patella tendon management. And to be honest with you, most of my reading and my expertise is around that. Now, my approach, however, still very much is similar. I just felt the need to state that just in case anyone wants to get overly sciencey on me. Additionally to that, there are about 6 to 7, if not 8 different theories out there as to how this condition actually occurs. But again, for the purpose of this talk, we do not need to go into that, and I do not need to bore you about it. I am simply going to tell you how I approach things based on my reading and my interpretation and my experience. There are also different treatment approaches out there. And to be honest with you, also loads of people debate about where the pain actually comes from. So lots of things that are still a bit debatable. But in regards to where things actually go wrong, tendinopathy, or the pathology around tendons, is considered to be a load accumulation injury. So what I mean by load is it's a force or a stress. Every step you take will involve a ground reaction force, which is some form of force or stress or load. Every movement you make is some form of load or stress applied to the tendon or to your body in general. And there'll be a change in that efficient, complex, 3-dimensional structure that we spoke about earlier that causes tendinopathy. The research has shown that the more loading you do and the longer you do it for, the more likely we're to see some of these changes going on in the tendon, i.e. the longer you run for and the further you run for and the longer you're a runner for, the more likely we are to see some of these changes. Now, that does not mean that running's bad. I'm just saying that we see change in the more that we do. There's some sort of changes into and around the body. Now, apologies, this is a slightly complex chart, but we're going to simplify it in the way we talk about it. So if we take in the center here, your normal tendon, which is in that rectangle at the top here, I, for real simple terms, want you to imagine your normal tendon as a nice packet of uncooked spaghetti. Right down at cell level, like we were talking about earlier, the collagen fibers are produced by tenocytes, these small tendon cells. And those tendon cells will respond to every single stress you put across them. And in response to that stress, they're constantly producing new collagen fibers. And that helps us to constantly adapt to our environment. We know that we lose cells, we build up new cells, we'll lose collagen, we'll build up new collagen. And if that process is nicely maintained, we have a nice, normal, healthy tendon. I'm going to emphasize the fact again that we need to load the tendon if it's going to stay healthy. The tendon cells need it. So if those tendon cells are constantly loaded within a zone that they're used to, and within a capacity that they're used to, then we get this nice adaptation process. However, for some reason, if there's a stress outside of the tendon's capacity, I mean, some of those cells, if they're loaded outside of a zone that they're not used to, these cells start to respond differently. They produce some proteins that are a bit different. And if that happens over a long period of time, the collagen fibers that start to get laid down, in short, rather than looking like these nice long bundles of cooked spaghetti, we start to get some of these fibers that look a little bit like uncooked spaghetti. Now, remember, I'm talking about part of the tendon. This is not the whole tendon. So overall, we're getting a disorganization of the collagen fibers and a loss of this nice 3-dimensional structure that I was talking about earlier. And it's that that apparently affects the tendon's capacity to tolerate the stresses we put across it. Now, just to make things a little bit more complicated, is when we start to look at those changes I was talking about and the pain or the symptoms that people present with. So I could take 25% of you and I could run an ultrasound scanner over your Achilles tendons, and I'm likely to find tendon changes in that 25%. However, what will be really, really interesting is that not all those people will have pain. So ultimately what I'm saying here is that you need to have some form of change going on in your tendon to have pain, but you don't have to have pain if you've got these changes going on in your tendon. Yeah, a little bit confusing, right? So what is it that all of a sudden takes this tendinopathic, this change in structure of the tendon, to it being painful? Well, what seems to be the causative factor is some form of overload. Or actually, if I'm going to be more specific, it's a period of underload followed by a period of overload. For example, in clinic, the classic new year, let's lose that weight over from the holidays. I'm going to go out running every day, or I'm going to start running. Certainly in the case of the pandemic, people weren't able to get to the gym. So I started to see a lot of people taking up running or running more frequently because they had the time. All of a sudden, there was this new stress that started to tip people over into this overload around their tendons. The same can happen from a pair of changing shoes. Now, this is not always the case, but sometimes shoes can go from a really high stability shoe to a minimalist shoe. In some cases, people's tendons are all of a sudden, shocked as to where their stresses come from, and symptoms can start to appear. The same can occur from a period of offload following an injury. So you've had a fracture, we've offloaded the injury, and then we're getting you back into your activities. If that happens a little bit too fast, then again, tendons can start to react. Now, there are a number of other factors that can obviously contribute to this, but this just gives you an idea of the sort of thing I'll start to see in clinic. So in regards to research, what's it currently telling us? Well, as I said earlier, we absolutely know that tendons need to be loaded to stay healthy. We take away stress from the tendons, we lose condition. We also know that there's poor correlation between structure and symptoms, as I said earlier, in regards to the imaging. I want you to imagine now, there is purpose for the donut. I want you to imagine your tendon, or a tendinopathic tendon, is like the donut. And the hole in the middle is actually the area of disrepair, or the uncooked spaghetti, the cooked spaghetti that I was talking about earlier. Now, in regards to pain, it appears that the nerve endings around the sheath of the tendon, which is a lining, are what cause the pain. So almost imagine the little sprinkles on top of this donut are like the little nerve endings around the sheath or the lining of the tendon. Now, from a research perspective, we know that if we get rid of those nerve endings through kind of certain types of injections and stuff, we can get rid of them. We know that the pain goes away, and it can go away sometimes weeks, if not months. However, no magic answer here, they do grow back. So yes, we can get rid of pain, but if we don't do anything else, that still grows back. So as physiotherapists or treating clinicians, we can't just focus on pain here. Additionally, if we come on to point number 4 here, we also know from the research that there's lots of healthy collagen fibers. So as I was saying earlier, part of those fibers look like cooked spaghetti, but we've also got lots of those uncooked fibers. And actually, the research has shown that in a normal tendon, compared to a pathological tendon, there is actually more of the healthy cooked fibers than there is in a normal tendon. And that simply tells us that your body is trying to respond. It's trying to heal itself. And effectively, that tendon is still healthy and can still tolerate load. It's just pain that's limiting us here. Lastly, I need to emphasize that none of these fibers are torn. This tendon is still able to tolerate load and it is not at risk of rupture. And that's really, really important for anyone struggling with their tendons to be aware of. Right, away from the complex stuff, and let's look at the clinical stuff. So how do these present? How does a tendon problem tend to present? Well, they're slightly unusual in that it's not the same as your classic acute injury. If you get an injury from a muscle, you'll tend to feel it at the time. It will swell, it's consistently sore if you load it, and it's pretty obvious if you've done too much because it lets you know. A tendon, however, tends to give us small awareness, small amounts of awareness, small amounts of discomfort that, to be honest with you, might have not even considered to be a problem. It doesn't functionally restrict you, you can do all the things you want to do, but over time it starts to give you a little bit of a sign of there being a bit more of a problem. Furthermore, tendons lead us into a bit of a false sense of security because they ease as we warm up. They tend to feel a little bit better, so we think little of it, so we can carry on doing what we want to do, only for them to give us that latent discomfort. So there's that soreness after exercise. And this is a classic with tendons. They are always sore within that 12 to 24 hours after loading. Tendons are also locally uncomfortable. Now, this might matter more to me than you, but when a patient comes in to see me, they point to it. They point to the tendon. It's not as non-specific pain. They know where it's originating from. It may be spreading and affecting other areas the more you're dealing with it, but the discomfort is quite local. The discomfort is also creates a bit of stiffness after a period of inactivity. So classically, for example, your Achilles tendinopathy, when you wake up first thing in the morning, you take your first few steps, you're limping for a first few steps, and it may take a few hours for that to ease off. Your gluteal tendinopathy, so that high hamstring one that we mentioned at the start. Let's say you've taken a really long journey down to the coast to go on holiday, you get out of the car, really, really uncomfortable after that period of sort of sitting on it. And this kind of fits in also to that sort of period of compression that I'm mentioning on the next point. Tendons hate compression. So this is a really interesting one because this is where stretching comes in. And it may feel nice for you to do it at the time, but tendons hate being stretched, certainly in that really early phase. So again, lying on your side at night, your supraspinatus tendinopathy, your rotator cuff tendinopathy, really uncomfortable when you first wake up in the morning. That can merge over with a few other problems, but tendinopathy very classically. Again, as I said, you're stretching, you yogis with your high hamstring tendinopathy may feel nice at the time, horrible afterwards, and I can speak from experience. So yeah, take out this stretching, they don't like it. And lastly, this is again probably more specific for me, but in regards to those tendons that you can feel, so probably the Achilles being the most obvious, they tend to get a little bit thickened. So in comparison to the other side, you might find that there's a little bit of swelling around it. There may be slight nodules to the tendon. It may have a sort of fusiform sort of nature to it. Again, just touching on that topic, if your tendon is squeaky, however, we're not talking about tendinopathy. So if you get a kind of grindy sort of sensation, it's what we call crepitus. This is actually the sheath of the tendon, and it is a different problem, and it will be managed slightly differently. right, so you're going to come and see me, hopefully, if you've got a tendon problem. What am I going to do about it? How am I going to approach this problem? What sort of things am I looking for? I'm going to perform a really, really detailed assessment. The questions I ask, the assessment I go through, the history of your symptoms are all really, really essential. So sorry for all the questions. Sorry, but not sorry. Tendons have a really clear pattern in how they react, and they're very clear in regards to the things I mentioned earlier. So that most people will mention those when they come into clinic. If it's not the case, i.e., for example, if these tendons are not worsening after loading, I'll really question the diagnosis. And obviously, this is essential. Your diagnosis is really important, because if we're not dealing with a tendinopathy, then the treatment program we're going to put into action is not going to work. And if you want to get better, your diagnosis is going to match your treatment program. I also need to assess your level of function. I need to assess where we're starting from. How do you move? What can your tendon do? How much can it tolerate? And how does it react when I load it? Can you tolerate what you need to do in response to the desired task that you want to do? So if you're wanting to run, can you hop on one leg without pain? If you can't, well, no wonder you can't run. I then want to set those goals. What is it that you want to be able to do? This gives me an idea of where your treatment program is going to go. It helps me talk you through where we're starting, where we need to finish. And that helps, obviously, us to be clear from where we're starting, and helps you avoid any disappointment, hopefully. Now, obviously, well, the treatment program is never a dead straight line. There's always ups and downs. But if we're both on the same path, we both understand where we're going, then we can work well together. And then we start to move on to the treatment. So it's my job to restore function. I need to think of you not just as that tendon problem. I need to think about you as a whole unit. I need to rebuild a robust system, and so everything needs to be looked at. And this is really important also for you to consider, because it's important that we affect the tendon locally, of course, but we also need to think about how that tendon connects to the muscle and the muscle tendon unit, and how that affects to the surrounding joints, how you move effectively through the kinetic chain. Can you jump and land effectively? Because if you can't, that's going to affect how that tendon is working. And then I need to think about how your brain is responding or connecting with both. Do you have confidence in your movement? Do you have confidence in the program? Because again, all of this kind of feeds into one another. And if there's dysfunction at one level of this, then you're likely to continue to have tendon pain, again, at some point, or you'll struggle to complete the tendon program. So effectively, we're having to restore function to ease pain, and the two come sort of hand in hand. Brief example, let's take your sort of classic left Achilles tendon pain. Got a patient that walks in through the door, they can't run, their tendon is so painful, they've got a half marathon coming up, even walking is uncomfortable, it's a bit of a nightmare, the marathon's in 3 months. So start to have a look and assess how that tendon is functioning. Patient comes in, I asked, right, let's have a look at what this Achilles tendon can do. Can you go up and down on your tiptoes? On the good side, yeah, no problem, 20 reps. On the bad side, oh, got to stop after 6, far too sore. So obviously, I'm not going to really test them from the hopping perspective, because if you're sore after 6 heel raises, no wonder that tendon is going to feel sore if I ask you to hop up and down on it. So this obviously explains why you can't run. My job as a physical therapist is therefore to get that tendon and the whole system to adapt and improve in its functional ability to tolerate the greater loads that it will be subjected to run a marathon. So I need to restore that general tendon capacity to get it back to its nice, full, fast, spring-like action that we were talking about earlier on in the talk. So how are we going to do this? exercise. I'm afraid there's no quick fix. I'm afraid there's nothing fancy here. It comes down to a boring, basic, simple form of exercise. Now, what's form of exercise? Well, more specifically, it's going to be a progressive loading program. So if we come back again to what we were talking about earlier, about tendons needing load to become normal or to maintain a normal tendon, this is where it's key. So stages. The first stage is often the most tricky. Effectively, we need to settle the tendon down. So if someone's coming in and they're trying to get away with bits here and there and it's up and down and all over the place, first off, we need to modify activity to enable the tendon to settle. We need to take away the things that it doesn't like. Now, again, the focus here is modification. It's not complete rest. That tendon still needs load, but we need to take away compression. So stop aggressive stretching where possible. Let's avoid prolonged sitting on really, really hard chairs if it's that high hamstring problem. Let's take a bit of stress off the Achilles tendon and put you in a heel or stick a heel raise in the shoe. Let's do maybe a little bit of taping to offload the stress that tendon is being subjected to. Whatever it is, just to enable that tendon just to settle. Now, funny enough, in this sort of early phases, there'll be various adjuncts that could be used. From my perspective, from a loading perspective, we tend to like to use what we call isometrics. Now, that's a static load applied to the tendon. So it involves no stretching, it involves no heavy force, but just a certain type of loading that's applied to the tendon that is actually being proven to have a pain relieving effect. As fast as possible, then we start to move into stage 2, which is some form of strength or different type of loading of the tendon. This is start to build some of these collagen fibers that we were talking about. And most importantly, at this stage, we don't forget the kinetic chain. I want to keep you moving. I want to keep you exercising. We want to keep all those positive endorphins going through your brain. It may not be the things you want to do, but it's important we keep you moving. We just do what we can to load the tendon and manage things into and around it before moving to stage 3, which is where the fun stuff comes in. This is if you want to do this sort of level of tendon function. If you want to just walk around the park and walk your dog, or whatever it is, if it's the lower level, then we may just stop at stage 2. But if you're wanting to run, if you're wanting to play a set sport, then we need faster movements from that tendon. So the exercises need to be specific to that. I need to start introducing more speed. We need to start introducing end range loads of the tendon. I need to start adding a little bit of compression now at this stage because the tendon demands and the stresses added to the tendon are going to start to change at this higher level. And then at the end stage, it's more sport specific. So acceleration, deceleration, are you needing to jump on one leg and then land and change direction and jump for a ball? Whatever it is, that tendon needs to withstand it. And we need to know that you can tolerate those loads without the tendon reacting. So the program needs to be designed very strictly. And as the clinician or the treating therapist, it's our job to load that tendon correctly. And it's absolutely essential it's loaded correctly. I do expect some discomfort, but the right loading is essential to see the right adaptations. If not loaded heavy enough, you may not get the right adaptations. And if loaded too heavy, we may see too much of a spark or a reaction within that tendon. Ultimately, I tend to be happy with round about a 4 out of 10. So 10 out of 10 was the worst pain you can imagine. 0 out of 10 is nothing. 4 maximum or below. And that's both during the loading as well as within the 12 to 24 hours afterwards. So prescription is key here. But you, as the patient, it's also essential that you're honest about what you're doing outside of the program, because we have to remember that the tendon loading program that I'm giving you isn't just the exercises, but everything else you're doing around it, I'm afraid, is going to have a role to play here. So I know you're going away for a weekend to go trekking. You've got a wedding and you're dancing away all weekend at the wedding. Those things, in the case of the Achilles tendon, for example, will have a tendency to really aggravate it. So if there are peaks in your pain, then, and you're going, I'm still doing all my exercises, then understand that that's also going to have a role to play. So I'm sorry, but sort of not sorry for not being able to give you a really set recipe here, because in short, I can't, because every single patient that walks through my door is different. Your physical condition will be different, your activity levels are different, your exercise experience is different, and I'm afraid on top of that, every single tendon is different. The patella tendon, the shoulder, the elbow tendons, the hamstring tendons, they all work differently. The loads they withstand are all different. So I simply cannot create a set recipe here that's followed by everybody. So a few common questions when it comes to these sorts of problems. Do you need a scan? Well, if we come back again to what I was talking about earlier in regards to sort of structure and well, pathology changes on the scans and pain or function, there's a really poor correlation between the two. So what's the scan going to tell me that I can't see in clinic, which is going to help guide what I'm going to do with you for your treatment program? To be honest with you, it's not. If anything, it tends to mean that patients come in, they're like, oh, I've got these, this area in my tendon, it's awful, I've got to be really careful of it. Well, so long as, don't get me wrong, so long as, there is no signs of tears within the tendon, which that can rule out, I know that there's going to be loads of healthy fibers there that I can load. So if anything, it tends to, create a little bit of fear around what we then want to do. So yes, there's a role to confirm diagnosis in some circumstances or to rule out the other problems, but it's not going to change what I'm going to do. Do you need to rest? Well, again, if we go back to what I was talking about earlier, absolutely not. This is a complete and utter disaster. Not only will you lose tendon condition, you'll lose strength in the muscle, you'll lose control further up the chain, and your brain will register those changes. You are only as strong as the loads you subject yourself to. If you rest, we know that you lose load capacity. So only if you're resting, basically, you're going to take longer to get better because we have to restore more capacity. What about other treatments? Sure, yeah, there are loads out there. And I'm sure if you go and see a therapist, we'll use a number of these. But they're all there to help you exercise or load the tendon. Because none of these are going to affect the change in those collagen fibers. None of those are going to have the effect to produce that nice, new, strong tendon that you need to do by yourself. So massage, acupuncture, taping, yeah, use them. And I use them to help settle down pain in the early stages to try and modify that tendon discomfort. Podiatry also really effective in those really acute phases. And sometimes also to help in the long term if we're talking about running biomechanics here. In regards to the top two, when we were talking about where the pain's coming from with those nerve endings, in some circumstances, they're really effective at giving us a window of opportunity to then load the tendon. So if I'm really struggling, if things are really, really aggravated, yeah, they have a role to play, but I would never use that at the first port of call. They are simply there as supporting mechanisms to try to get you to load the tendon. So what about preventing tendon issues? Well, if we look back again on what we've spoken about, we just reintroduce some of those things into our day-to-day life. So obviously here, training consistency is key. Tendons hate peaks and troughs. They hate sudden changes. Rough rule of thumb, don't take this exactly, but runners, I tend to say, 10% increase in mileage week to week. If you're very experienced, maybe a bit more than that. But otherwise, consistency is always going to be key. Listen to your body. You know how it works. We all know when we're trying to push that little bit too much, we think we can get away with it. Secondly, we all know it, but we hate doing it. Strength is key. As we get older, we get stiffer. Fact, our tissues are less elastic. We simply don't bounce back like we do when we're children, but we still can get stronger. We all expect that little bit more from our bodies as we get older. We're, if anything, more active, but we don't put the same level of care into it. And it's an incredible system when it's looked after. You just simply have to put the work in. To be honest with you, if you stop strength training, then ultimately you actually lose what we call an inhibitory drive from the brain. So when you're loading your tendon through the recovery phase, your body gets used to that, and we obviously will lose pain as the function improves. If you stop strength training, you will lose that inhibitory drive, which again will cause that discomfort to return, or has an increased likelihood of it returning. Progressive return if you have a period of time out. So you may have been a runner always, you have 6 months out, then you're going to go back and start running 10K 3 times a week again. Progressive build up. Again, rough rule of thumb, build up over a period of about 4 to 6 weeks. Tendons hate peaks and troughs. And the last one, stretching, always a bit of a debatable topic for me, but I often find patients, when they start a new activity or even on a day-to-day basis, they spend quite a lot of time stretching, not a lot of time getting themselves strong. Personally, I'd happily have it the other way around. Tendons, as mentioned earlier, hate compression. So if you're starting a new activity and you're spending all this time stretching, thinking you're going to spend time preventing injuries, potential recipe for disaster there. So not saying stop stretching, but horses for courses, let's work out what works for you. So what can we expect here when we're talking about or managing tendinopathies? This will take time. There's going to be ups and downs along the way. Commitment to the program and maintaining motivation in my patients is always the difficult bit, because I simply can't do the work for them. And it's often this that gets setbacks, and often that bit is what causes patients to become quite demoralized. Aside from that, your hours of ultrasound, your massage will simply not help change your tendon function. And in turn, your rest or avoidance of the exercise part of the treatment will only decondition your tendon further and result in longer treatment times. You also need to step away from the idea that your tendon, if you've had a scan, that your tendon is healing or that the structure is changing. So when we go back to that donut, we don't treat the whole, we treat the donut part. We need to focus more on adaptation of the healthy tissue. Adaptation of the healthy tissue we've already got, not the change of the tissue that's already sort of been disrepaired. So in summary, this is a complex issue, and it's one that's still very much being researched. It needs to be approached with care, and each case needs to be looked at very, very differently. You cannot expect to take a treatment program off the internet or to follow what your friend did next door. Each case needs to be looked at differently, and the approach needs to be taken carefully, designed around your history, your ability, and your goals. Disappointment otherwise is inevitable. The program is also progressive, and stages cannot be skipped. If you want to perform at a higher level, then higher tendon and general function, tendon and higher general function is required. Therefore, more stages of the program are going to need to be completed. For example, consider this a little bit like learning a language. You can't just learn all the vocabulary and then expect that you know all the language. It forms the building blocks, but everything needs to be done in stages before the whole thing can be pieced together. So yeah, it's much more complex than we think it's going to be. And lastly, they do get better. Yeah, they take time, they are tricky, but tendons do get better. Thank you for listening, everyone.
Thank you, Davina. That was a great presentation. I'm just going to stop the recording.